Hi everyone, and welcome back to our Prescribing in Surgery series. I hope you all enjoyed last week's webinar on fluids and electrolytes by Dr. Musa. Today we'll be covering antibiotics and blood transfusions. So yes, we'll get started. So again, a quick disclaimer, and just especially on this webinar today, a lot of the guidelines are very specific to your own hospital. So it's just important to remember that what we're teaching today, may not be exactly what is advised in your hospitals or with your protocols. So it's just important to cover the basics here today, but just to remember that you'll have to look up exactly what your guidelines say for specific hospitals in different places. Again, a just reminder, so today we're doing antibiotics and blood transfusions, and next week we'll be prescribing in pre-op. Okay, so straight into it. I would say before we start, I just suggest using either the BNF or antimicrobial companion to help with some of these questions. With some of the antibiotics, it gives very good guidelines. So case 1, 56-year-old man who's presenting with bone pain in his tibia. He's feverish and is having night sweats. He's recently presented with a penetrating wound to his leg. Past medical history includes type 2 diabetes, some hypertension, and ischemic heart disease. Drugs-wise, he takes glycoside, amlodipine, and atorvastatin. He hasn't got any allergies. And X-ray findings are in keeping with osteomyelitis. So we get an MRI and we're getting a tissue MCNS as well. And he's started on some antibiotics. And the question is, which antimicrobial agent would you be prescribing? So that's the first poll up. Okay, so we've got some answers there for vancomycin and amoxicillin. Any more? Okay, so the answer here is actually flucloxacillin. This is the first line normally for osteomyelitis, and it's normally given 4 times a day, and it's normally IV. So this is just to show you how we've got to that. So if you get up osteomyelitis on the BNF, this is what it says. So starting off with flucloxacillin and consider adding fusidic acid or rifampicin. And then in pen allergies, clindamycin, and using vancomycin only when there is MRSA suspected. I hope that makes sense. So case 2, we've got a 38-year-old man, who undergoes an emergency laparotomy following an abdominal trauma from a car accident. He's found to have ischemic bowel and undergoes a successful bowel resection. 48 hours post-op, the nurse raises concerns about him because he's febrile with a temperature of 38.1. These are his observations. So the question for this one is, how would you manage this patient? So if you have any thoughts on that, the poll is in the messages in the chat. Okay, so it looks like we've got this one right this time. Well done. So this is a classic case of sepsis. So we've got a patient, he's tachycardic, he's hypotensive, he's pyrexial, all cardinal signs of sepsis, and he's also got new AF, which is another classical sign. So with all sepsis situations, we want to follow the sepsis 6, which is 3 in and 3 out. So 3 in being your oxygen, your IV fluids, and your antibiotics, and 3 out, we want to take lactate and a full set of bloods, blood cultures, and a urine. So you want to put a catheter in. So we don't need to give any oxygen in this case because the SATs are 99%. So we don't need that. The key with sepsis is to try and give the antibiotics within 1 hour. I'm sure you've been told this plenty of times, but it's important to notate this down whenever you're initiating sepsis 6 and to raise it to a senior. And the paracetamol is just to take the edge off the fever, but it's not one of the main things. It doesn't have to happen. Okay, so you initiate your sepsis 6, you take your blood and lactate and your blood cultures, you put a catheter in and you monitor the urine output and you give some IV fluids and paracetamol. Get a chest x-ray, which is normal, and the urine dip is clear. So we're trying to find the source here, aren't we? On examination, he's peripherally cool, prolonged cap refill time. He's still tachycardic. His blood pressure's still a little bit on the low side. Chest is clear and his abdomen is diffusely tender. Blood glucose is normal, pupils are equal reactive to light, and his GCS is 15 out of 15. Calves are soft, non-tender. So at this point, we're suspecting he probably has an intra-abdominal infection, given that he's recently had surgery and we can't find any other problems in his urine or his chest. So which antibiotics would you want to be prescribing here? All right, so the answer here is C. So amoxicillin IV, metronidazole oral, and gentamicin IV at a dose dependent on the weight. So this was difficult. It doesn't actually come up in the BNF. So I use this as an example because it is a common situation, a sepsis where you're not entirely sure of the cause. At least up in Scotland here, we use triple therapy for this scenario. That is the IV amoxicillin, which gives you a good cover for gram-positive and gram-negative bacteria, your metronidazole, which covers for anaerobes, and your gentamicin, which is just a very strong aminoglycoside that covers severe infection caused by gram-neg and gram-positive organisms. So the answer can be found if you work out sort of the power of deduction. Linezolid is a very strong antibiotic. It's normally only initiated by microbiologists. Doxycycline and amoxicillin will cover the chest. Fluclox is used in skin infections, which is not applicable here. And Comox and Claro, a bit of a mixed combination, which isn't used for sort of a general sepsis picture. So this shows how the antimicrobial companion lays things out. I'm not sure if any of you used this before, but I really like it because it provides you with advice based on systems, so you can work through them and find the system that the infection is in, and then it gives you guidelines. So this is my local guideline, and I just want to labour the point here that obviously dependent on which area you're in, you need to use your local guidelines for each of these treatments. So I'm briefly going to just talk through gentamicin because it's very commonly used in surgery and it's very easy to get wrong. Again, I'm going to preface this by saying that the gentamicin calculations and calculators that people use in different hospitals vary, and so do the some of the levels. But this is quite a common one, I think. So the main steps are calculating your dose of gentamicin. 2 is reviewing the gent level and using nomograms to dose adjust. And then 3 is reviewing the patient and the blood results for side effects. And it's also just valuable to remember that you need to dose adjust for extremes of body weight and in renal function. So those are the things that we're looking to monitor. So quickly about gentamicin, we only use IV. It's normally renally excreted, which is why we need to check the renal function and dose adjust if they've got reduced renal function. It's normally only used for 48 to 72 hours. So you should only really be giving them 3 doses. And even if they need to have it less frequently than 24 hours, and you still only be using it for the 48 to 72 hour limit, because longer than that and the risks of nephrotoxicity and ototoxicity really go up drastically. So important to just check for these signs before you start using it and every time you prescribe it. So things we're looking for with nephrotoxicity is reduced urine output, oliguria, or any kind of increased creatinine, reduced eGFR, and ototoxicity, we're looking for any new tinnitus or hearing loss. So there's multiple ways to go about calculating the dose, but the easiest and the commonest way in the hospitals is using an online calculator. So I know in the PSA, you wouldn't have this, but in clinical setting, it's normally always an online calculator. Failing this, there are manual calculations which you can do, and failing that, there are weight-based doses if there are no results. It's worth knowing that blood gases can sometimes give you a creatinine, so it's always worth checking these to see if there's a creatinine before prescribing. And to be honest, if you're starting as an F1 or F2, you'd probably be wanting to either use the online calculator or the manual calculation, and maybe escalating to a senior before you start just giving doses based on the weight. Also, just to note down here on point 3, that there's a reduced dose for those with CKD, with CKD5. So I would personally recommend running that past a senior as well, and it depends on specific guidelines as well on what they use for doses. And then the next thing is actually prescribing the dose once you've calculated it. So it's important to prescribe it on your Cardex, so your written prescription, or online. And we always prescribe it as the chart. And we don't want to put in specific doses normally, because they can vary based on each dose, as you'll have to adjust it each 24, 48 hours. So this is an example of the online calculator that we use in West Lothian. So you just input your patient detail. You'd need a weight, a height, sex, and creatinine, and it works it out for you essentially. So once you've given the dose, you then need to take a gent level between 6 to 14 hours afterwards, and that will then inform your dose. So this is then the graph that we use. So as you can see, it's got time since the dose was given on the x-axis, and this means you should ideally be taking it 6 to 14 hours after the dose is given. Again, trusts differ, and sometimes trusts ask you just to take the gent level 2 hours before the dose, so make sure you just check which trust guideline before you do yours. But if we work with this example, where they use this kind of nomogram, you need to look at the level and see whereabouts on the chart level falls. So you've got 3 options. Either that you're giving the dose every 24 hours, or that you're giving the dose every 48 hours if it's in the middle, or the dose is too high and you'd need to withhold and recheck to see that the level's coming down, and raise it to a senior. Okay, so this is just covering what we've already discussed. Just a reminder to check the renal function before re-prescribing. And if you're taking a gentamicin level, so sometimes you'll have to order when the level's going to be, and hand this over to the doctors and the nurses. And at least where we are, we use the use and ease bottle for the gentamicin. And just a quick recap of that nomogram. So make sure you're comfortable with this before you start working with it. And this is just a quick slide of metronidazole. So in general surgery, it's used a lot as it covers anaerobic bacteria. So it's important to note this antibiotic has just as good a bioavailability orally as it does IV. So unless the patient has malabsorption or issues with their swallowing, we should normally use an oral route. And it's important to mention that the patient should be advised not to drink whilst on metronidazole, drink alcohol, that is. But yeah, it's really important if we can use it orally. It's much cheaper, and it reduces the workload on your staff, and it's got reduced risk of line infections. So in the clinical setting, really important to use metronidazole orally if it's possible. Okay, so moving on to case 4. So our same patient with likely intra-abdominal sepsis undergoes a CT, which reveals a collection. He undergoes a washout in theatre and has 3 days of triple therapy. His inflammatory markers are declining and the patient's now aporexial, so he's improving a bit. The surgeon asks you to convert him to an oral equivalent of the antibiotics for the further 5 days. Which antibiotics do you want to IVOS him to? And for those of you who haven't seen the term IVOS, it's just the IV to oral switch. Okay, so here the answer is B, so cotrimoxazole and metronidazole. So we don't really have to switch that because it's already oral. So again, there's no reason to really know this on the off the back of your. Sorry, I think I just cut up there. So what I was just saying is there's no real reason to know this off by heart. It's just something you can look up and become familiar with. So this is again from my own trust guideline on the antimicrobial guideline, and it gives you an IV switch, an IV to oral switch. So you just look up which infection you have, and it previously gave us the triple therapy, and now it's told us what to switch it orally as well. Okay, so case 5, we've got a 77-year-old man who's admitted with a fever and feeling generally unwell. He's got type 1 diabetes, Alzheimer's, and COPD, and he's found to have a diabetic foot with necrosis of 3 of his toes. He has a penicillin allergy. He is reviewed by the vascular team, and that's his weight and height. He's got MRSA. So which antibiotics would you want to be treating this with? Okay, so I think a lot of people got this one right. So the answer is cotrimoxazole and vancomycin. So the key here is that he is MRSA positive. And important to note here, he's got a penicillin allergy, so he can't be given the flucloxacillin or the pip-taz. So piperacillin and tazobactam is a penicillin. This is the BNF for diabetic feet infections. So you can see how we got there under treatment summaries. And you can see at the bottom, the option is vancomycin needs to be added in, which has a dose based on creatinine and weight. So this is just a note here. Lots of antibiotics involve a penicillin antibiotic, as we've seen, and often these are the most appropriate antibiotic and the best for treating the issues. So this slide just shows you how to delabel a penicillin allergy. Again, depending on which hospital you're working in, which trust you're at, they may be more or less comfortable with you doing this as a junior. In Scotland, they are keen on us doing this score and telling a senior about it with the option to maybe use a penicillin. So lots of people come into hospital with allergies for penicillin, and most of them don't have real penicillin allergies. So this is a score that you can do to work out how likely it is that they do actually have a true penicillin allergy. It's something we call the PenFast score. So questions we're asking are, is it more than or equal to 5 years since you've had a reaction to a penicillin? The A stands for anaphylaxis or angioedema to a penicillin previously. S is for any severe cutaneous reaction, and then T is any treatment required secondary to the reaction. So were they admitted? Did they need adrenaline? Anything like that. So if they have 0 points, they've got a very, very low risk of having a positive penicillin allergy. So it's less than 1%. So in people like this, sometimes it can be appropriate to actually trial giving an antibiotic which has penicillin in it, obviously whilst they're in hospital and whilst they're being monitored to see if they actually are allergic to it. But as I say, be cautious with this because you don't want to give penicillin to someone who does actually have a penicillin allergy. Moving on, so this is case 6. We've got a 62-year-old lady who is triaged through to plastics for a severe dog bite affecting her hand. So she's got damage to the nerves and the tendons, and it will need reconstruction. She is afebrile, and has a news of 1 for tachycardia, and she's given some analgesia. She's got no allergies, and she's previously got some CKD and hypertension and diabetes. Which antibiotic treatment would you give to her? Okay, so we've got lots of votes for Kermoxiclav. It's just whether it is IV or oral here. So the answer is IV. So we want to give Kermoxiclav 1.2 grams 3 times a day IV. So in bites where there isn't any penetration to the bones or the joints or the tendons, we can just give them oral Kermoxiclav. But because it's gone into the tendon, she's going to need IV. And other things that you'd want to be considering with someone like this would be tetanus jabs and maybe rabies jabs as well. So just to be aware of that. And this is where it says, so we've all got to Kermoxiclav, but it does suggest Kermoxiclav under human and animal bites. And it gives you a bit of information there about which cases would require IV and which ones would require oral. Okay, so I think we're going to move on to blood transfusions now, having done quite a lot on antibiotics. So firstly, we're just going to run through the steps for blood transfusions. So firstly, you need to recognize when a patient actually needs blood and a transfusion. Then you need to make sure you've sent up an up-to-date group and save and order the blood from the blood bank. Then we'll need to prescribe the blood on the paper prescription, how many units, what kind of blood product, and then we need to monitor for side effects and evaluate if they need any further units. So here we have a 54-year-old lady who is 1 day post-op following a hysterectomy for a definitive treatment of endometriosis. So she's feeling well after the operation and she's very keen to get home. So we've got a set of bloods that are taken before she is discharged. And the question is, what would you prescribe for her? Okay, so we've got a few different answers going on here. So the answer here would be oral ferrous fumarate, so 210 milligrams once a day for 3 months. So the important thing to look at here is that her hemoglobin is above 70, and that's normally the cutoff for getting an infusion. She also doesn't have any symptoms at the moment. She said she's feeling well and she's keen to go home. If we run through her blood results quickly, so she's got a low hemoglobin, so she is anemic. Her mean cell volume is low, so that's telling us she's got a microcytic anemia. And one of the causes of this is iron deficiency. And this is shown by the ferritin and the iron also being low and the transferrin being high. Her vitamin B12 and her folate are normal, which is good. So in this case, there would be no need for us to be giving red blood cells IV, and there'd be no need for an iron transfusion either because she's got good absorption. So oral ferrous fumarate would probably do the job. So this is just the BNF on red blood cells and ferrous fumarate. So again, the guidelines for each trust vary. But if we look at the red blood cells from the BNF, it suggests sort of the threshold and the targets of when you should be giving it. So the threshold is normally 70, and she's not got any symptoms. So she's not in need of red blood cells. And then the BNF for ferrous fumarate shows it's the treatment for iron deficiency anemia, which we know she has. And initially you start with 210 milligrams once daily. And you can increase it and you can decrease it. It does make people very constipated, which is one of the reasons people don't like taking it. But they only need to be taking it once a day. Sometimes people are prescribed it 3 times a day and it doesn't actually increase the amount particularly. So it's best just to stick to once a day if they can tolerate that. So this is a slide just to touch on IV iron replacement. What we use is Ferinject. There are, again, multiple different types of IV iron that you can use. And it depends on the guidelines, all depend on your local policy. But if there's an issue with malabsorption, so if you've got problems with malabsorption or poor compliance, so they're not taking the tablets, or if they've got swallowing issues, then it might be the case that they need to have some Ferinject, so ferric carboxymaltose, sorry, that's a mouthful. And at least for our guidelines, that's the one on the left at the bottom. It shows you how to work it out. So it's based on the hemoglobin and the body weight. So anyone who's less than 100, hemoglobin less than 100 is technically eligible to get it. And then it's based on the weight. And they normally have 2 doses a week apart. Okay, so this is case 8. Our final case. So we've got a 65-year-old man here who's awaiting surgery tomorrow for severe aortic stenosis. He's admitted and has a set of pre-op bloods taken. Past medical history includes congestive heart failure, severe LVSD, previous MI, and CKD4. Drugs include atorvastatin, bisoprolol, amlodipine, isosorbide mononitrate, furosemide, aspirin, and apixaban. So here are his bloods. Sorry, there's no reference range, but his hemoglobin is low. His white cell count is normal. His sodium's slightly on the low side, but it's all right. Potassium, again, is on the low side, but in normal range. His albumin is very low. His EGFR is low, and his creatinine is high, but this is all fitting with his CKD4. So final question is, what would you prescribe for his anemia over what time frame, given that he's going into surgery tomorrow? Okay, so it looks like most people got this one right again. The answer is D. So we'd want a weight-adjusted red cell dose, and we'd want to monitor O2 sats and give a diuretic. So the reason for this is because we're looking out for pulmonary edema due to volume overload from transfusions, which is called TACO, so transfusion-associated circulatory overload, which I'm sure you've heard of before, and it can occur in high-risk patients when we transfuse them. So it's the leading cause for morbidity and mortality relating to transfusion. And to screen for it, we do a TACO assessment before transfusing all our patients. So if we just work through our other answers to work out why this one was the correct one, we don't want to be giving 2 units together. So that rules out A, erythropoietin isn't going to raise the hemoglobin overnight. So that's inappropriate. C isn't wrong as such because deferring the blood transfusion is a smart idea, but in the scenario where he needs an urgent operation and his hemoglobin is too low to go into theatre with it, so he is going to need a transfusion. So we can't really defer it, and he is incorrect because we don't have any of the TACO precautions in place. Okay, so this is the TACO assessment. So we look for risk factors such as congestive cardiac failure, aortic stenosis, LVSD, anything relating to pulmonary edema or use of diuretics, and any renal impairment or hypoalbuminemia. So our patient had a lot of these, CKD, congestive heart failure, taking furosemide and a low albumin. So he was a very, very high-risk patient. And this slide just shows us some of the considerations we should be taking if the patient requires a transfusion but does have a TACO risk. So normally on the blood transfusion prescribing sheets, there's a section which has all the TACO risk factors on, and you have to go through and check them and then state if they have a TACO risk or if they don't. But if you were to have to go ahead, things that we should be thinking about, we should be using a weight-adjusted dose. We should only be transfusing single units at a time, and we should be using a diuretic at the same time and monitoring the fluid balance. And you should also monitor their oxygen sats to look out for early symptoms of TACO. So if someone does present with TACO, they normally have a new O2 requirement, they're normally tachypneic, tachycardic, hypertensive, maybe a fever, and that's normally in the patient 12 hours, up to 12 hours post-infusion. And you'd probably get a chest x-ray, and that would show you some pulmonary edema, and the treatment involves stopping the transfusion and giving diuretics and giving oxygen that's required. So I guess this was just to highlight the complications and the actual requirements for blood transfusions, because quite often we're quite quick to think that that's the answer for everything, but actually it's just important to think about the risks involved and actually if there are other alternatives that they can be given. Okay, so this is just a summary. So we've discussed the use of the BNF, an antimicrobial companion for antibiotics. And I know I've said it multiple times, but just to always use your local trust guidelines. Being aware of allergies when you're prescribing antibiotics, and especially penicillin allergies. Steps for prescribing gentamicin, we briefly touched on, using oral metronidazole over IV when it's possible, and then steps before prescribing blood. So things that you need to go about doing, your group and save, which has to be up to date, ordering the blood, doing a TACO assessment and rechecking bloods afterwards, and prescribing correct blood products. So thinking about giving oral iron versus IV iron versus red blood cells, and equally you might be giving folate or B12 if that was low, and things like that. And these are my references if anyone else needs to find any of the information. So that's me finished for today. I hope that was helpful. I'm going to put a feedback form in the group if it's okay, if you'd be able to fill that out, it'd be really, really helpful. We are trying to make changes as we go along based on what you say so that we can try and make sure these sessions are up to date and the best they can be for you. So thank you very much for doing that. And as I've mentioned before, next week we'll be with Dr. Musa, and she'll be touching on prescribing it in pre-op. So thank you very much and have a lovely evening.